Nobles is a graduate of the James Madison College at Michigan State University. She earned her degree in Social Relations and Policy in Women, Gender, and Social Justice. She is a longtime activist of reproductive rights, previously interning at Planned Parenthood Affiliates of Michigan, and is a past board member of the Michigan Religious Coalition for Reproductive Choice. Shannon currently works as Resource Center Coordinator for the Michigan Resource Center on Domestic and Sexual Violence. And she's going to talk about what the Hyde Amendment and what efforts that mirror the Hyde Amendment have meant for low-income women. Shannon?
Thank you, Joy. So I'm going to kind of break it down into 4 different portions. First of all, just a brief background on the Hyde Amendment, followed by some information on Medicaid, information on pregnancy as a result of sexual assault, and then barriers to accessing comprehensive reproductive health care for low-income women. So first we'll start a little bit with the Hyde Amendment. The Hyde Amendment is a legislative provision barring the use of certain federal funds to pay for abortions. As a rider attached to the yearly appropriations bill for Medicaid, it occasioned intense debates in Congress each time it came up for renewal. Mostly due to the fact that this original measure made absolutely no exceptions for cases of pregnancies that were the result of sexual assault, specifically rape or incest, or threatened the life of the pregnant woman. As a result, beginning in 1977, language was added to provide for such circumstances. However, the exact language, the exact wording of this language varied from one year to the next. Therefore, it became subject to the outcome of congressional bargaining on the issue. So you still see a lot of debate over the Hyde Amendment. So we have this as a rider to Medicaid. So I wanted to kind of talk a little bit about what Medicaid is. Medicaid was authorized in 1965 and stands as a joint federal-state program that provides the nation's low-income population with basic health and long-term care coverage. Medicaid is the largest health care program in the United States and covers more than 50 million people. Under Medicaid, states receive federal matching funds to provide health care for low-income individuals. Medicaid coverage is critical to the health care of millions of women. More than 16 million women receive their basic health care and long-term coverage through Medicaid. In 2003, Medicaid covered 1 in 10 women and 1 in 5 low-income women. And in that same year, 11.5% of women of reproductive age were covered by Medicaid. Currently, all state Medicaid programs must cover pregnant women who meet the federal income requirements. Many states have elected to cover women with incomes that are a bit higher than the federal requirements. However, the coverage is not without limits, and abortion services are among the provisions that are the most highly regulated. Currently, Michigan stands as one of 32 states that pay for abortions for low-income women only in the cases of life-endangering circumstances, rape, or incest as mandated by federal Medicaid law. In 2004 to 2005, 64,080 women were raped, and this is according to medical reports. So we know that approximately 60% of all sexual assaults are never reported, but of those reported figures, 64,080 women were raped in that period of a year. And according to the medical reports, the incidence of pregnancy for one-time unprotected sexual intercourse is 5%. By applying the pregnancy rate to 64,080 women, RAINN estimates that there were 3,204 pregnancies as a result of rape during that period. A few notes on the calculation of this figure, though. The calculation does not account for the following factors which could in fact lower the actual number of pregnancies. Specifically the definition of rape that RAINN, which is the Rape and Incest National Coalition, uses to define rape. So the definition of rape stands as forced sexual intercourse, meaning vaginal, oral, or anal penetration by the offender, and it includes incidences where that penetration is from a foreign object, including a bottle or something of that nature. So certain types of rape under this definition could not cause pregnancy. Also, a rape victim may be utilizing birth control methods such as the pill, which would prevent pregnancy, And there are some rapists who wear condoms in an effort to avoid DNA detection, which would then lower the chances of pregnancy. And finally, victims of rape may not be able to become pregnant for medical or age-related reasons. There are also a few factors to note that could, in fact, increase that 5% statistic of pregnancy for rape victims. Specifically, that 5% rate are for one-time unprotected sexual intercourse, and we know that many victimizations include multiple incidences of intercourse, which would increase that 5% chance, or 5% statistic. And also because of methodology, they do not measure victimization of Americans aged 12 or younger, and we know that rape of these young people could result in pregnancies that are not accounted for in national figures. So this 5% of rapes resulting in pregnancy is kind of an average to go off of, but there are factors that could increase or decrease that number. So we know a little bit about what the Hyde Amendment is and how it affects Medicaid coverage, and then we know a little bit about the picture of women in the country who are having a pregnancy as a result of this sexual assault. So now we can talk about kind of combining it all and these unique barriers to accessing comprehensive reproductive health care, which seems to target low-income women. So there are unique barriers for low-income women accessing the comprehensive reproductive health care. Barriers to abortion access, such as lack of providers, state laws delaying women from receiving timely care, and funding restrictions, specifically the Hyde Amendment, fall disproportionately on low-income women who have limited resources which to overcome the obstacles. So according to the Guttmacher Institute, they found that 20 to 35% of Medicaid-eligible women who would choose abortion end up carrying their pregnancies to term when public funds are not available. Additionally, lack of public funding results in women waiting while they raise those funds, which then postpones their abortions until later in their pregnancies when the costs and healthcare risks can become much higher. For women who are struggling to make ends meet and who do not have insurance that covers abortion care, the legal right to have an abortion does not guarantee access. In Michigan, from October 2009 to December 2009, Medicaid paid for 16 abortions. Again, some things to note on these figures. This number of 16 in that quarter does not distinguish between abortion in the case of saving a woman's life and abortion due to pregnancy from rape or incest. So it just looks at the rare circumstances that they could cover abortion. In that 3-month period, 16 were paid for statewide. And the Michigan Department of Community Health, which is the department in the state government that captures these figures, were unable to say whether the number was consistent quarterly or not. But the most recent data that they had available that they could share was October 2009 through December 2009. So we can see that there are a very small number of abortions per year, if we were to kind of take that as an average, that are being paid for by Medicaid for low-income women in need. What I wanted to do next is kind of talk about how this can be covered, how Medicaid is run and the approval process for covering abortions in these circumstances throughout the state. So we recognize that Medicaid only covers an abortion performed by a physician and related hospital charges when it has been determined medically necessary to save the life of the mother or the pregnancy as a result of rape or incest. The funding is not available for any elective abortion services related to performance of abortion unless one of these criteria have been met, right? And they're not going to provide these services unless we can justify that it is a life-saving necessity or it was rape or incest. And in order to do that, the physician must certify on a completed certification for induced abortion form that for medical reasons an abortion was necessary to save the life of the mother, or the beneficiary's medical history indicates that the terminated pregnancy was the result of rape or incest. So there has to be proof medically that there was a rape or incest. And we kind of talked a little bit, I discussed the statistic that 60% of rapes, or 60% of sexual assault in general, is not reported. There are many reasons why a woman would choose not to report or not to go through with a forensic medical exam. But if a pregnancy resulted from a rape or an incest that was not reported to police or was not gone to the emergency room to have one of these sexual assault nurse examiner examinations, there would be no proof, right? So those pregnancies would not be considered something that could be covered. So you need to have this proof, and the physician who completes this form must also complete the beneficiary verification of coverage form, and they're responsible for providing copies of these forms for billing purposes to any other provider that would submit claims for services related to the abortion. So an anesthesiologist, a hospital, a laboratory, and then the doctor themselves. All of these different types of providers that would submit claims have to have this proof that the pregnancy was a result of rape or incest in order to then go ahead and get coverage from Medicaid. So the medical record itself is going to have to include this complete beneficiary history, including any medical conditions and any medical history that would prove that the abortion is necessary to save the life of the mother, or the explanation and the circumstances around the pregnancy as a result of rape or incest. And that circumstance part is a little bit unnerving for me as a sexual assault advocate, that you have to have all of these circumstances and history on medical records in order to get that coverage. And all of this breakdown of the procedure can be found in the Medicaid Medical Provider Manual, and it can be accessed online. But specifically, this is what medical providers have to follow this process in order to get any claims paid for by Medicaid. And the Michigan Department of Community Health is the organization responsible to the federal government for administering the Michigan Medicaid program in compliance with federal law. And this eligibility determination is done not by MDCH, who submits the claims, but rather by the Department of Human Services in the state of Michigan. So there's an agreement between DHS and DCH to determine whether or not these claims can be made and paid for by Medicaid. So you can see that for women who are available or who have funds and resources to pay out of pocket for abortion, they have less barriers to receive that procedure, whereas a woman who is of low income or lower socioeconomic status, who does not have the resources to go out and receive an abortion on her own, there are a lot of obstacles to receiving one through Medicaid because of the Hyde Amendment, even when it's necessary to save her life or it's a result of a sexual assault.